So firstly, welcome to this education session being hosted by the West London Haemoglobinopathy Coordinating Centre. And I think for all of us, this is a particularly important topic focused around pain management in sickle cell disease. And all of those of us who manage patients with sickle cell will recognise the importance of this area. Acute pain being the most common indication for admission to hospital among patients with sickle cell disorders, but being only part of the tip of a very large iceberg, which I'm sure we'll hear much more of. And as evidence has evolved around particularly chronic pain management, I think we're at a point in caring for patients with sickle cell disease with a wider repertoire of interventions that can help in the long-term management of chronic pain. So I don't think any of the speakers really need an introduction. They'll be well known to all of you, but I'm very pleased to welcome Dr. Kofi Anie, who's going to introduce the session this afternoon with the first talk.
Thank you, Mark. I will share my screen. Can we all see it?
Yes.
Okay, good. So I'm basically going to introduce the subject today. I'm asking a question: what is sickle cell pain? And I'll try and introduce it within the context of the different types of sickle cell pain that we have, mainly in terms of acute and chronic pain. So sickle cell pain, I think, from the point of view of the majority of patients and also clinicians, is sometimes defined as the hallmark of sickle cell disease. That's because it's persistent and significant in terms of, being problematic for patients. But also, patients actually do show wide variations in pain experience. That is from one patient to another, as well as from one individual's episode to another. So sometimes the challenge is not in terms of what actually happens broadly, but from the individual experience. Sometimes they might say, I've never had pain in this part of my body before, or I've never had that sort of pain before, and that experience is kind of different for the first time that occurs. But also, we know that the impact of pain on the daily lives of individuals is quite important in terms of how they function from a day-to-day basis. But the big problem that hopefully we can sort of try and address today is that management of sickle cell pain has a lot of difficulty, and this is historic as well. So by definition, let's look at the dimensions of sickle cell pain within the context of pain broadly. So they do have sensations, and that's the physical sensation of the pain. But also importantly, from the psychological point of view, it involves their emotions in terms of mood, for example. And then what they do in terms of how they respond to it behaviorally in terms of actions. That is their coping ability. But also, I think it's quite important because there's a previous experience that also plays into that pain experience for the current time as a dimension, and that gives a perception. So if the previous experience wasn't very good or was quite negative, that would affect how they would experience the pain at the present time. And then also their expectations in terms of the outcome. So patient comes in, or a patient is seen within the clinical setting, and they have a certain expectation of what might happen. Some people might expect that their pain will resolve quite quickly. Some might expect that, it might take a certain length of time to resolve. And that is all quite important when we are looking at pain broadly. So in terms of assessing pain, especially in the, let's say, acute setting, it's basically a subjective estimate, or a verbal report. So we ask the patient how they feel in terms of the pain, and we might ask them a pain score, for example. But what makes it challenging is that there is discordance between the clinician and the patient. So if you ask patients how they are feeling in terms of the pain, as a nurse, as a doctor, as a psychologist, or whatever, the literature broadly suggests, and also experience also broadly suggests that, the estimation of the pain by clinicians is actually much lower in terms of, let's say, the intensity or the experience that patients feel is quite different from the patient. And when it comes to children, actually, they do ask, parents an estimation of their child's pain if the child obviously is too young to verbalize or articulate it. And I think that's where some of the issues do arise because of that big difference. And actually, I think it's very important because a lot of times you might hear, let's say, nurses or whatever saying, oh, the patient is not actually in pain. But then when you speak to the patient, they do say that they are in pain and it's a certain intensity, but the fact that they are able to do other things to, let's say, distract themselves, I think that's where a lot of the challenges come along. So some people might see the patient, maybe on the phone or, on a computer or something by the bedside. And when they go and then they ask the patient how they feel, and the patient reports the pain in a certain way, asking for medication, that creates that sort of problem. And so there is obviously misinterpretation and a lack of understanding, and obviously from the point of view of the patient, sometimes they feel that people or clinicians are looking at them and saying they are exaggerating the pain, especially when they are asking for an analgesia, which is not within the context for which the clinician might see the patient from that point of view. So that is very challenging, and that's very difficult. But we actually do have, the only NICE guideline for sickle cell is to do with acute sickle cell pain. This was published in 2012, and it was kind of reviewed, but it hasn't really changed that much. But I think some of the key recommendations are that, patients should actually have individualized assessment of their pain, and in a lot of cases we try and do that by providing, for those who require individual pain protocols, as well as trying to, if we actually do follow the guideline, then we have to try and assess them properly, especially when they come through A&E and then ending up on the wards as well. And then there's a focus on the primary analgesia in terms of how quickly one can get, them to have adequate pain relief. And sometimes they do get some pain relief in the ambulance, and then they end up in A&E, and that leads to what they get initially. And then also a key area is that, we need to reassess the pain in terms of how we manage the patient continuously within the hospital setting or the acute setting, which could be like a day unit, for example. But I think, interestingly, one of the key things that was also highlighted in the NICE guideline was that we should look at complementary interventions. At the time, unfortunately, in terms of the literature, there weren't a lot of non-pharmacological interventions that could be included in the guideline, but that didn't negate the reason why we shouldn't look at that. So obviously psychological approaches, as well as other complementary therapies, were highly recommended as well. So we'll look at chronic pain. We'll have a separate talks, especially on that. But just to define it, in terms of, let's say, the WHO definition, is that pain that would last for 3 months or more. And this is usually quite demoralizing and quite stressful for individuals. It does require a lot of emotional resilience. If you talk to patients who have chronic pain with sickle cell, it's really very challenging. They tend to talk about things like helplessness and hopelessness, as well as having feelings of anxiety and depression being very common. It also poses a burden to the family, friends, and other support networks that they have. And I think it's something that needs to be considered very carefully in terms of the management of sickle cell pain in general. But there's something that I would like to categorize as chronic sickle cell pain, just because sometimes by the definition that we have, you might have certain patients having, let's say, for example, avascular necrosis that would cause them to have continuous pain on a daily basis, on top of just having frequent sickle cell crises. But I think we should also look at the fact that some patients actually get frequent sickle cell pain episodes, like crises, which can be on a day-to-day basis. And there might be 1 or 2 days in between that they would not experience that pain. But I think overall, if you look at it over a period of time, I would put that into a category of what you could call chronic sickle cell pain. And just to highlight this, there was a study done, a large study done in the USA some years ago, which showed that when patients were given a diary for 6 months, 29% of these patients who were adults reported that they had sickle cell pain every day. And also, in our own sort of trust, in our own area, just looking at assessing patients, especially just before they leave the hospital, so on discharge and up until 7 days post-discharge, we'll phone them up just to see how they're feeling, and then they'll still report that persistent pain. And a lot would also report that their daily function was not restored for some time. So I'm sure that if we sort of keep in touch with them, for a longer period of time, post the 7 days, you probably be able to capture some of that information that was covered in the large American study. So looking at some pain assessment tools, basically, these are the things that we use in the acute care setting. You might use it also for chronic pain. It's, you have numeric scales that could, sort of be the typical, but also sometimes I find out that it's interesting, especially when it comes to children, including things like faces and that. And for some patients, and this is basically that, you're trying to probably give them, you could use, colors to differentiate sort of how they would rate their pain or would score their pain. Another pain score that's quite useful that some people actually use is that they don't actually put any numbers, and the patient just has to put a line, and then based on that you can calibrate what the pain score might be. But I think the majority of patients would have a good sense of how much pain they're feeling. But sometimes I think we need to be able to capture other aspects of the pain. And this is something that we tend to use, which basically gives an idea of the pain score in relation to things like mobility and self-care from a standard tool as well, and also being able to capture things like drowsiness and the mood of the patient. It's not very clear, but I could send you a copy if you want. And then going on, just to touch briefly, our focus is going to be on other aspects, but just to touch briefly on how, in terms of WHO definition, how we should look at managing pain on a 3-step ladder So when you have mild to moderate pains, you look at non-opioids, for example, NSAIDs, non-steroidal anti-inflammatories, and things like paracetamol fall into that category. And then looking at moderate to severe pain, where patients might look at using mild opioids, which may include things like codeine. These they can readily use at home. And then for severe pain, looking at more strong opioids such as morphine, with or without non-opioids. So in conclusion, I think sickle cell pain requires a multidisciplinary approach in order for us to achieve effective management. Thank you.
Thank you very much, Kofi, for introducing this subject to us so clearly. And we'll move on now to Jeremy Anderson, who is the clinical psychologist working with the specialist hemoglobinopathy team at Imperial. And Jeremy is going to talk about his experience in managing pain, including chronic pain in sickle cell disorders.
Okay. Thank you, Mark. I'm just going to actually share my screen as well. So I'm hoping actually to talk today about, I'm actually going to focus a bit more on acute pain, and I think we'll leave the chronic pain to Rebecca. Can everyone hear me?
Yes,
yes, we can.
Okay.
Thanks.
Okay,
Thanks.
great. Okay, so what I wanted to focus on today is thinking about how do we help patients who are in acute pain, so people who attend hospital, besides giving them opioids. And so, you know, as Kofi mentioned, the NICE guidelines require that we give people pain relief, in a specific period of time, and there's a lot of focus. And they do talk about complementary therapies, but nothing's really been specified. And there may be times where we don't want to give people opioids, and I'll go into that in a little bit. So what I wanted to talk to you about today is to think about how we can use psychology and our understanding of psychology to change patients' memories of their pain experience. We can actually change the way people think about the pain, as Kofi was mentioning. People's expectations for outcome can be important. And so I wanted to highlight some of the challenges in providing patients with acute pain relief beyond just getting them opioids within 30 minutes. And then I was hoping, if we have time, and I'm just going to actually start my timer to make sure I don't go over, I'd like to actually think as a group maybe what we can do to try to improve people's pain experience, even if we can't give them more opioids in an acute context. And so I know we're going to do a panel at the end, but at some point I'm hoping it'll be a bit more interactive, so people feel free to jump in. And if I'm saying something that doesn't make sense, feel free to jump in and ask a question. That's fine. So much of my presentation today is going to be based on the work of this guy. This is Daniel Kahneman. And Daniel Kahneman is probably the most famous psychologist in the world at the moment. He basically invented the field of behavioral economics. And if you don't know what behavioral economics is, a behavioral economist is basically a better paid psychologist. But Kahneman won the Nobel Prize in 2002 for his work that he began in the 1970s with his collaborator Amos Tversky. And basically, Kahneman and Tversky and a number of other people following have really opened the door to our understanding of what are called cognitive biases. And so in the years that have followed, you can find this compendium online of all of the different cognitive biases that human beings are subject to. And the idea with biases is the whole point of your brain as an organ is just to take in all of this information of your environment and help you make decisions and navigate through the world. But of course, there's way too much information. And so your brain doesn't take in all the information. It filters a bunch out, and then it has to decide what to remember, but it doesn't remember everything. A lot of what we experience isn't worth remembering. So there's some little tricks that your brain has in terms of how it's wired that allow us to remember just the most important things, to act fast even when we don't have enough meaning or enough information, or if there's too much information. And so there's a whole bunch of cognitive biases that affect the way we perceive and remember our experiences. And so what I'm going to be talking about today is one called the peak end rule, because I think that's going to be relevant to pain. But before I get to that, what Kahneman and colleagues talk about is this idea that you have more than one self. You have the experiencing self, and you have the remembering self. So the experiencing self, that's the self in the present moment. That's the you, that's the conscious you that's experiencing all of the sensations and thoughts and experiences that you're having right now. Whereas the remembering self, again, you're thinking about your experiences, but it's in a memory. And so it's the difference, when you have a patient in the hospital bed and you say, where does it hurt right now? You're asking that person to think about their experience in the present moment. Whereas if you walk into the bay and you ask them, how has your pain been? Well, maybe now they're thinking about how it's been in the past, maybe over the last several days or last couple of weeks. And so you can actually get two different answers, because the way we remember a thing can be very different from how we actually experienced it. And the important point here is most people's intuitive idea of how memory works is that memory is sort of like a recording, and that when you access a memory, it's basically like rewinding the cassette tape in your brain and just playing it again. But that's not really how memory works. It's not about laying down a recording. Rather, every time you remember something, you're constructing it on the fly. And the way we construct it can change the way we remember an experience. So, the peak end rule. How you remember an event, how good or bad it is, really depends on two things. One is the peak, that is, what's the maximum feeling or emotion or sensation you had, and then how did it end? So if you have if you go on holidays for a week, you're not going to remember all of the experiences of that week. Really, you're just remembering snapshots, the most important thing, and then you tend to remember how it ended. So if the vacation ended well, you tend to remember that as a really good vacation. If it ended badly, even if the first 6 days of the week's vacation was really good, if it ended badly, you tend to remember it as a bad vacation. And so this can apply to both positive and negative events. So it could be the way you remember your vacation, but also it could be how you remember painful experiences. Another important point is the idea that the length of the experience doesn't actually matter. So if you go on vacation for 2 weeks, you won't actually have a memory of that vacation that's twice as good as a vacation for 1 week. And that's because the experiences you're having in the first and second weeks are largely the same in terms of how good or bad they are. The number or the duration of the vacation experience doesn't actually make the experience better. Okay, so how might this work for pain? So, coming back in 1993, they looked at how the peak end rule might affect people's experience of pain. So when psychologists want to study pain in the laboratory, what they do is they invite usually undergraduate students in and subject them to a specific controlled kind of pain experience. And one common way of inducing pain in a participant is what's called the cold pressor task. So the cold pressor task here, we don't see any ice in the water here, but what you can see in the picture there is someone sitting and they've got their hand submerged in some cold water. And so what Kahneman and colleagues did is they had a person come in and submerge their hand in water that was 14 degrees Celsius for exactly 60 seconds. Now 14 degrees Celsius doesn't sound that cold if you're from Canada, but it's actually cold enough to cause some pain. And so that was the first thing they did. And then what they did after that 60 seconds in trial 2 is they had the person put their other hand in another a cold water bath at the same temperature, 14 degrees Celsius, for 60 seconds, and they had them rate that pain. But before taking their pain out, or their hand out of the water for 60 seconds, they raised the temperature in the bath to 15 degrees Celsius and had them hold the hand in there for 30 more seconds. Now 15 degrees Celsius is still painful, but it's slightly less painful than 14 degrees Celsius. So then what they had people do is they had them rate the experience, and they asked them, which, a couple of days later, they'd ask them, which one would you like to repeat? What do you think? Everyone's bashful.
Trial 2.
Trial 2.
Yeah,
absolutely.
Trial 2 because it's warmer.
Because it ended well, right? They said they would be more willing to repeat trial 2 than trial 1, okay? So keep in mind, trial 2 has all the pain of trial 1, right? They did the first 60 seconds at 14 degrees, plus they did the extra 30 seconds. So they had 30 more seconds of more pain. It's just not quite as bad a pain. But because it ended better, participants remembered it as being more pleasant, or at least less unpleasant. So that's a laboratory example. So how do you think things might work in the real world with medical procedures? So Kahneman and colleagues repeated this in 2003, and what the procedure they decided to look at and see what they could do was colonoscopies. So I have no pictures for this one. We're just going to have to work with words here. So what they did was they had two groups of participants. One group had a conventional colonoscopy, and I've not had one, but colonoscopies, at least they used to be quite painful. And so for this group, they would get a normal colonoscopy and they would rate their pain throughout the procedure for that. In group 2, this is the modified procedure. They had a normal colonoscopy that was just as painful as the first group. But then what they did for the modified procedure, at the end of the colonoscopy, they actually left the probe inside for 1 or 2 extra minutes. So this is still painful, but it's less painful when the probe is not moving compared to when it's moving. And so just like with the cold pressor task, the procedure ends with pain, but a little bit less pain. And so here are the results for this. So what we see is they had people rate the initial pain, the pain at the middle of the procedure, and the final pain. They had them rate the peak pain, and they had people estimate the average pain over the whole procedure. And what you can see is none of these things are significantly different except for the final pain. That is, the people with the modified procedure rated the final pain as significantly less than the people with a normal colonoscopy. And then a couple days later, they asked people to rate the pain of the procedure. And what you see on the right here is basically, in retrospect, the blue line represents their rating of the pain. So people in the modified procedure rated their pain as less than the standard procedure. And the orange line just represents actually more time. So this just emphasizes that even though people with the modified procedure, had the probe inserted for an extra minute, so it's an extra minute of pain, people are still reporting less pain. And what's interesting is they followed up and they found that the patients in the prolonged discomfort group, that is, the people who remembered the pain more positively, were actually far more likely to attend a repeat colonoscopy, because the less painful end caused them to remember the procedure more positively. Okay, so what's any of this got to do with sickle cell? Well, we have patients who come to us in acute pain. They may attend A&E or a pain day service, or they may get admitted acutely as inpatients. They may attend for procedures that are also painful. When patients attend with acute sickling, often we can provide them with opioid pain relief and a la the NICE guidelines. And when that works, there's no problem. That fits with the peak end effect. If they come in with pain and we give them pain relief and they feel better at the end, then that's great. Then they go away and they remember that experience positively. That's when everything works well. But what about when things don't go well, right? There's many ways that this cannot go well. So what if you can't give them what they want, right? What if they've attended too many times? What if they don't have evidence of acute sickling, but they're still in pain? What if you give them opioids, but it doesn't work? If people have been taking that level of opioids at home, they get used to it. And so they stop getting pain relief, even though you're giving them pain relief. What if, for example, a patient who's been through a pain management program like what Rebecca's going to talk about next, what if they've cut down their opioids and they're saying, look, I don't want you to give me opioids, but I can't cope with this pain on my own? What do you do then? So just like Kofi was saying, pain is both a sensory and an emotional experience. There's the sensation of pain, but it really is an emotional, unpleasant experience to have pain. If a person is saying they can't cope, they're probably not, we think about coping as behavioral, but they may not be able to emotionally cope either. And as a doctor or a nurse, you may not be able to take the pain sensation away, but maybe we can do something to help the emotional part. And so what I'm wondering is, what do you do either in your clinical practice right now, or what do you do, even when you have people in your life who are experiencing pain? What do you do to help them? And so the example I'm thinking of, I don't have any kids, but I was a kid once. If anyone has any kids, like, what do you do when a 5 or a 6-year-old, falls off their bike or something and they skin their knee? If you've ever had, your child or a niece or a nephew have that experience, that's immensely painful for the child, and they cannot cope emotionally, right? If you've ever had that kind of experience, when a kid skins their knee, they absolutely lose their mind, right? They're crying, they can't handle it. That's all they can focus on, right? And what do? Well, you don't give them morphine, but you do something. You soothe their pain, right? So you come along, you say, oh, that looks terrible. Let's get you cleaned up. Maybe you carry them home. You reassure them. You give them a hug. You make sure that they know that they're cared for, right? So this quote here, I found this on the internet. It's making the rounds. I'm not actually expecting people to take this literally. Please don't kiss your patients, at least not in the COVID era. But the idea here is that when people are hurting, they want some kind of human connection to help them cope. And so I'm wondering, what are some ideas we have? Maybe you're already doing this. Maybe you don't need me to tell you a bunch of things you should do. But when patients come into your departments and they're saying, I'm in pain and I can't cope, what are the things that you do already besides giving them opioids? What do people do? Are people bashful again?
Empathize, make eye contact.
You empathize, right? You want people, like, people want to know that you care, and you can show them that you care by listening to what they say, right? By paying attention, right? Maybe you want to help them stay calm, right? Why would you want to help them stay calm? Has anyone seen the movie Inside Out? Do you know what I'm talking about? The Disney movie?
Yeah.
It's this film where sort of there's like a committee inside the kid's head of emotions, and it sort of explains things. There's a character, the sad character, who can just sort of turn the thoughts blue or more sad, basically just by touching them. And I think that's a really good example. Not that people are in pain are necessarily sad, but the emotional valence that feeling distressed or emotional or upset about something when you're in pain, it really puts a topspin on the experience. And so when people are super stressed, if we can help them calm down, we actually help their experience of pain. What do you do to make people comfortable when they come in?
The focus tends to be on the environment. Like
right. Get them a bed or a comfortable chair, right? Make sure the temperature is okay. Do they have a pillow? Do they need a blanket? All of these things, trying to make people feel more comfortable, right? And even if you can't give them exactly what they want, right? You want to communicate them that you're there to help them. You want to do everything you can, right? So maybe what they want isn't appropriate, but you're not just going to give them nothing. You're going to give them something to try to help and see if that can help, right? If nothing else, you're going to let them know that you're there. You're not suffering alone, or they're not suffering alone. You're going to be there with them, right? Okay, I think I'm just about out of time, so thank you very much, everyone. So I will.
Thank you very much, Jeremy.
Okay, you're welcome.
I'm sure there'll be a lot of questions and discussion about some of the issues you raised, particularly the importance of a holistic approach to managing pain. So it's a very great pleasure now to invite Jennifer Thompson, who's a member of our patient and public voice group within the HCC, to give a personal perspective on this important topic. So thank you very much for joining us, Jennifer.
Hi, thank you so much, Mark, and thank you for having me. I will try not to be very long, I hope. I'm going to, can everyone hear me? Sorry, I probably should check. Yeah.
We can, yes, thanks.
I'm going to attempt to share a presentation, so apologies if that doesn't happen. Oh gosh. Oh goodness. Okay, I don't think it's happening. So I don't know if Ralph is on and Ralph has. But if not, that's absolutely fine. I will just if you.
I think Ralph has it. So.
Oh, okay, right. Okay. Oh, sure. Perfect. Okay, so if everyone can see that, that's amazing. So yeah, so as Mark said, my name is Jennifer Thompson. I am a 30-year-old female who suffers from sickle cell disease or sickle cell disorder. And I thought I'd just share, I guess, a first-hand experience of what both the physical pain of sickle is like, as well as the psychological sort of elements to the disorder. So next slide, please. In the next, yeah, if we just click all of them, yeah, and then I'll just go, yeah, thank you. So physical pain and its effects. Sort of, I guess, as physicians and medical staff, and as a sickle cell patient, the question that we get most asked is, what, you know, score your pain, or what does the pain feel like? And I think for a lot of sickle patients, it is quite difficult to put into words and to explain what that pain feels like. So I did have a think, and I tried to sort of try to think of a quite visual way to maybe describe it. So oftentimes when I'm asked, I describe it as having somebody chiseling or hammering at your bone continuously. So in that, you're not only feeling the sort of immediate impact of that hammer or that chisel on that part of your bone, but there's also the kind of shock waves or reverberations that then go through your bone. So there's kind of like almost like a secondary wave of pain. And that particular thing that I've just described sort of happening everywhere. Other sickle patients that I've spoken to have described it as having like multiple fractures or multiple broken bones, and then what feels like glass sort of flowing through your body in terms of those sharp shocks. And then I've read an account on a blog of another sickle cell patient who has described it as, imagine tying a rubber band on the edge of your finger and just tying it over and over and over again until you can't tie it anymore, leaving it on for about 5-10 minutes and then snapping that band off. That initial sharp pain that you get in your finger, so imagine that being essentially inside your bone and that sort of happening continuously. That's, I think, kind of some of the ways that I know, and, you know, and reading all of those and hearing other patients talk about them, instantly I know what they're talking about. So that's something, I guess, is the closest way I can describe to what the physical pain feels like. Other aspects, I guess, of the physical pain of sickle is just how debilitating it is. So, you know, it's sort of sickle crisis, as you probably have all known and seen patients with it, when a crisis hits you, no matter where you are, and it hits hard, and you can go from being, you know, I can go from being independent, going out shopping, thinking about what I'm going to do in my normal day-to-day life, and then a crisis hits, and no matter how independent you are, sort of, you know, you get to a point where you can't sit, you can't stand, you can't lay down, you can't, you know, pick up a pen, you can't feed yourself, and you go from being somebody who's, you know, probably very independent, capable of doing everything normally, to not being able to assist yourself without somebody else. And then that goes on to the next part, which is the frustration part, in that it's for me anyway, it's a constant struggle when you're in the midst of an acute sickle cell crisis, I should say anyway, and also sometimes a chronic one, but I'll touch on that a bit later. In the sort of the midst of your crisis, there's this constant struggle between what you want your body to be able to do and what your body can or therefore can't do. And this is in itself sort of exacerbates the psychological effects of the pain, because it's very much a pain of the body and not of the mind. In that sense, you feel very capable in your mind, but your body very much does not, and it's trying to remedy those two things. And you're sort of, you know, you're lying in bed, you're thinking of all these amazing things I could be doing, I should be here, I should be there, and you literally can't even pick up a pen. And I think that's a constant struggle that I know as a sickle cell patient I struggle with quite a lot. And then the next thing that I was thinking of, which I think sometimes is one of the more overlooked physical effects of sickle pain, is exhaustion from the pain itself. So you're going through this horrendous pain, and sometimes, depending on how bad that crisis is, and on that scale that Kofi was talking about, sometimes the worst crisis pain you've had in your life. And the nature of the pain and how relentless and incessant it is, you find yourself, so the pain sort of almost goes through peaks and troughs, but the troughs aren't pain-free moments. There's still very much a baseline of pain, but then you get that, as I was saying with the hammer and chisel, you get that sort of sudden impact, or that peak of pain, and you find yourself almost tensing your body in anticipation of the next wave of pain. So you're constantly doing that for however long your crisis is. That can be a few hours, that can be days, that can be weeks, that can be months, and you're tensing yourself in anticipation of all of these waves of pain to try to, maybe you're thinking, okay, if I'm ready for it a little bit, maybe it won't feel as bad as the last time. And that leads to a sort of physical exhaustion, because you're using your muscles to kind of prepare yourself for these waves of pain. So I think that's when I think about my when I'm in a crisis, that's probably one of the things that I maybe don't articulate maybe to my team. It's just how exhausted I am from the pain, because your main focus is just getting rid of the bone pain, the kind of the crisis pain. So next slide, please, Ralph. Thank you. So then I was thinking about the psychological effects, and for me, it wasn't until probably my mid-20s that I started to even acknowledge or understand how much of a toll sickle has had on me and does have on me. So I say that to say that, I mean, there absolutely is a psychological, component to sickle, but I like I'm saying, in my younger years when I was in pediatrics, and even when I moved into adult care for the first few years, I didn't really acknowledge the psychological, or I was unaware of the psychological part, because again, when you're in that much pain, your most immediate thoughts and worry is just about how do I stop myself feeling this physical pain. Everything else almost becomes a bit of a kind of secondary back burner type of need. But one of the ones in speaking to like sort of people around me about, it's just the change in mood, and you're in pain. So, and that this also comes from chronic pain as well as the acute pains. When you're in pain, and I'm sure most people, not just sickle cell patients, can, hopefully identify with this, you're a little bit more short with the people that are around you. You're a bit more, you're a lot more irritable. You're kind of, your patience wears thin quite quickly. You're not really in the mood for a lot of, things and socializing and things like that. And so that's something that, in terms of when I think about that in times or in days when I'm either pain-free or have my pain score is a lot lower, it then brings on a sudden, oh my gosh, I was really mean to so-and-so, I didn't mean to snap at this person. But again, these are things that you kind of don't, in the moment when you're in the pain, you don't really realize it. And it then kind of brings a secondary wave of feeling either embarrassed or shameful that your whole mood has changed, and you've kind of become slightly this person just because of the pain. Then there's the kind of your mind and body misalignment, which I kind of touched on a little bit when I was talking about the physical pain. And for me personally, that's one of the hardest part of dealing with my disorder as a whole, in that sickle cell can be a bit of a sort of, I guess what I describe a Mr. Hyde, Dr. Jekyll kind of disorder, in that when you're quote unquote fine, or outwardly you appear fine, or you're not in as much pain, you're not having an acute crisis, you very much feel in your mind that you want to be able to do all the things that you want to achieve. You want to be able to do things like how normal, quote unquote, healthy, people your age, your peers, live their lives and do what they want to do. But internally, you're constantly struggling with what you're capable of doing, and you're constantly on this edge of what can I do but not push it so far that I get a crisis. So your disorder is constantly in your mind. It's constantly at the forefront of everything that you're thinking of and you're planning, and you want to go to the shops, but it's now the middle of winter. Will this 10 minutes trip to the shop, would that cause you problems when you come home? You want to go on holiday, where it's a constant, or you want to commute to work but your hip has been playing up. What's the best thing to do? Do you call in sick? Do you stay at home? Do you not? It's a constant struggle with what you feel that you're capable of doing and what you want to be capable of doing, and what your body will not allow you to do. And I know for me that's been a constant struggle throughout my whole life, and having sickle, and especially much more so when my chronic pain became a a much more present force in my life with my avascular necrosis, in that it doesn't then just become the acute pain and, you know, a very finite time that you can't do something. It then takes over essentially your whole life because it's an everyday thing. Then there's also the aspects of feeling like a burden to those around you. And again, because of how debilitating the pain can be, and like I mentioned, you can go from being absolutely fine, being able to do everything yourself, and depending where you have your crises and who's around you, you then have to sort of almost in an instant put aside all feelings of shame or feelings of pride, because you're so helpless and you're so powerless within your own body that you need whoever's around you, no matter who they are, to be able to assist you and help you and sometimes save your life. And that, you know, after one or two times you're thinking, oh, okay, well, but the more it happens, the more you then kind of take on this feeling of like, oh, I don't want to go out with my friends if I feel a bit poorly because I don't want them to have to look after me. Like, you then start to internalize those feelings of being a bit burdensome to other people and to those around you. And then one of the other ones that I sort of was thinking of in terms of the psychological effects of sickle pain, chronic and acute, is a kind of feeling of an inability to let go. And I say that in the sense of, in my experience, my sickle cell care hasn't been uniform and hasn't been the same across all hospitals. I definitely noticed that there's a certain type of care that I receive from big hubs such as like St George's, who are very familiar with sickle care and sickle pain. And then when I've had a crisis or had to attend smaller localized hospitals who aren't so aware with it, the knowledge isn't uniform across all of those places. So what I have found, you know, since I've been an adult, since my parents have stopped having to come with me to hospital and I've been an adult caring for myself if I've had to go in for a crisis, is I have this constant need to feel like to feel like I have to be alert and I have to be fully engaged in what's going on, because to get the best treatment, or to make sure that everybody understands what sickle cell is, you know, to understand that I have a protocol and that they're following the protocol, and to kind of feel like I get the best care, I feel like I have to be alert and engaged in that care. And if you can imagine, you're already going through, you know, at sometimes a level 9, level 10 pain, and then still feeling like you're unable to just kind of let go and let people do their jobs and do what they need to do. And I think I don't want to say that as in it's no disrespect or anything to the teams, or to feel like you don't have trust in them. That's not what it is whatsoever. But I think as a sickle cell patient, I'm sure many patients have the same experience. When you go into A&E, sometimes your protocol isn't followed, or, you know, you're not being asked the right kind of questions, or you're waiting for treatment, you're waiting for care. And if you're not switched on and asking for what you need, or making sure, you know, it's been half an hour, or actually, you know, I've had this pain medication 40 minutes ago and nothing's happened, is there anything else I can have, or what else? If you're not on the ball, sometimes you feel a little bit like, oh, okay, maybe I'm not going to get what I need to be able to bring this pain level down. And I think that's another psychological effect of the pain, is just this constant need to always be so engaged, even when you are at the, you know, kind of your absolute limit in terms of physical pain. And I think for me, usually the sooner I know that I come into an A&E clinic or healthcare facility, the sooner I feel that the team around me are asking me the kind of right questions, in like, do you have a protocol? What have you taken? The sooner then I usually tend to feel like, okay, I can tap out of this care situation and just focus on calming myself down, you know, trying to go somewhere in my mind to feel more relaxed so the pain doesn't feel as bad. And I think that's something that I know a lot of other sickle patients go through, is this constant need to feel like they have to be alert and they have to be very present even when they're in the midst of a really bad crisis. So my next part was just thinking about what I was thinking is, from my perspective, what I would feel like would be helpful to me as a sickle patient if I was coming in with an acute pain, or if I was coming with some chronic pain. And I think this has probably been touched upon, but looking at sickle, or taking a holistic approach with sickle patients, and that absolutely the physical pain, for me anyway, is always the number one thing that I'm trying to reduce or get rid of. But there are the psychological burdens that comes with that. And I think feeling supported in those is definitely also incredibly helpful, and looking at my pain as a whole, rather than just here are drugs to stop the pain. And that's absolutely essential, but I think a holistic approach to it is really helpful, would be helpful for me. And also communication with patients, just feeling listened to when you're in hospital, when you're talking about your pain. I think Dr. Anie touched upon this in terms of sometimes when your pain has come down a little bit, so on the surface you're on your phone or you're having a conversation, your distraction is a really big part of taking your mind off the pain. So outwardly you look like you're in less pain or you're fine. That doesn't necessarily translate to reality, in that you could be still in a lot of pain, but it's just less than what it was. Sort of like a pain scale 9 is still less than a 10, but it's still pretty bad, and you're just trying to distract yourself. So I think feeling listened to as a patient, when I say I might be smiling with the nurses and we're chatting about what I'm going to be doing when I get out of hospital, but if 10 minutes later I can say I'm in a lot of pain still and I feel like I need something, or what can I have? I think feeling listened to is a really big part of, I guess, the care that I would like to receive anyway. But yeah, so that's I hope this, I don't know if it lightens some of the experiences of a sickle patient, but I'm happy for any questions also. I think at the end there's some time.
Thank you very much, Jennifer, for those personal and very powerful insights, and I'm sure it will lead on to an active discussion shortly. We're going to finish the educational session with a talk from Rebecca Mcloughlin from St George's, and many of you will know that St George's has been in the vanguard of developing a multidisciplinary model for management of pain in patients with sickle cell disease, which is being adopted by other centres as a paradigm. So very interested to hear Rebecca's presentation today. Thank you.
That's great, thank you very much. I hope that I'm just sharing my screen. Just give it a second. Yeah, I'm getting the nod from Jeremy. Yes. Yeah, great, thank you.
Thank you.
Great. So I'm going to spend a few minutes today talking about chronic pain in sickle cell disease, and specifically about the role of pain management programmes, which, as Mark said, we have developed specifically a pain management programme for people living with sickle cell disease at St George's, and it is really great to see Hammersmith following and about to roll out their virtual programme very soon as well. So through my presentation, I'll briefly discuss the evidence supporting pain management programmes for adults with sickle cell disease, and try to discuss who might benefit from a pain management programme and how people can benefit. I'll introduce you to the Breaking the Cycle programme, which is the programme we run at St George's, and really briefly consider some aspects of the type of approach that we have that might be incorporated into more brief clinical encounters. So, as Kofi discussed right at the start of our session today, both acute and persistent or chronic pain are now acknowledged as evident in sickle cell disease. Persistent pain is described as pain that's present on most days over a period of 3 to 6 months. That varies a little bit in that kind of time frame, but it's that ongoing, often people describe kind of daily pain. And there's a very helpful publication, recent publication that I've just put on the screen there by Oswunko and colleagues. And they very helpfully highlight that persistent pain may be present in one or more locations in the body and can be present with or without evidence of contributing disease complications. And I think that can be a very helpful thing to highlight. It's quite well established within other forms of persistent pain, such as persistent back pain, that there may be little evidence of ongoing injury or damage in the area that pain is perceived. But in sickle cell, sometimes we've maybe related pain or looked for it to be related more directly to a disease complication, but there's increasing acknowledgement now that there may not be evidence of an ongoing disease complication, but persistent pain may well be present for individuals. And as Kofi talked about, the prevalence of persistent pain in sickle cell disease is thought to be very significant, and many papers discuss that it's probably underreported within the sickle cell population. So in the last few years, there have been some very helpful evidence-based standards of care documents released in the UK and USA, I'm sure you're all familiar with. And both the Sickle Cell Society document and the ASH guidelines that were published last year advocate the use of cognitively and behaviourally based self-management approaches, including pain management programmes, as part of a comprehensive pain management approach for adults with sickle cell disease. Both documents also recognise that there is a need for further research in adults with sickle cell disease, as the evidence that's drawn on in our current guidelines is extrapolated from a very small number of papers, largely looking at pain management approaches in young adults with sickle cell disease, and then most evidence is extrapolated from other non-cancer related persistent pain. So our evidence base specifically in sickle cell for adults is quite small at the moment, but because of the low kind of risk of these approaches and the perceived benefits, they are being advocated. So what exactly are pain management programs? Many of you might be familiar with them, but just to kind of clarify, they're group interventions and they're run with a closed group. So the same attendees, the same participants and facilitators run the entire course. Across persistent pain management programs, they can vary quite significantly in length. So less intensive pain management programs might be around kind of 20 or 25 hours of clinical contact. More intensive programs can be up to 70 hours of contact, so they can vary quite a lot in their intensity, but they often follow something around an 8-session model, which is quite common in behaviour change approaches, with some kind of follow-up, often maybe 1, 6 and 12-month follow-up. So they're really interventions that are looking at a block of input that is hopefully going to encourage longer term behaviour change and improvement in quality of life. And those follow-ups are very important in supporting that behaviour change in the longer term. Another really important aspect of pain management programmes is that they're facilitated by an interdisciplinary team. The aim of pain management programmes is that they try and address the broad and varied impact of persistent pain. And in order to really look at all of the aspects of life that can be influenced by persistent pain, we really want that input from different professionals working together. So clinical psychologists and physiotherapists are very common within the team, and usually there's some input from nurses, occupational therapists or medics as well. So pain management programs are often described as person-centered programs, that even though the content, there might be a framework for the content that's delivered, the aim is that the content is personalised to the individuals in the group and that it really helps them to work towards their individual goals and to address the specific impacts that pain is having on their life. They're described as a complex package of interventions. So within the programme, a number of different strategies will be suggested, education will be delivered, different behavioural approaches will be introduced, and behaviour change will be suggested and experimented with. And it's this combination of lots of different approaches that an individual applies in the way that suits them best that we think brings about helpful change. And the aim is that pain management programmes increase quality of life, reduce disability and reduce distress. Many programmes report change in pain experience, but this isn't identified as our core aim because we can't always guarantee that, as well as we can guarantee or kind of work towards improvement in quality of life and function. So as I've said, there's a very large evidence base for use of pain management programmes broadly across persistent pain, but their use in sickle cell is kind of emerging. And we're really lucky in this region that we've got 2 centres developing pain management programmes for the sickle population. So who might benefit from a pain management programme? The British Pain Society suggests that pain management programmes are the intervention of choice for people with chronic pain that adversely affects quality of life and where there's significant impact on physical, psychological and social function. So we can start to get an impression of the impact that persistent pain is having on lots of aspects of people's lives through patient-reported outcome measures. And most pain management centres and programmes will ask participants or people being assessed for a programme to complete a battery of outcome measures to start to give an impression of the impact and the change that has been brought about through pain and potentially the benefit of the input that the person has. But some of the best indication that we'll get and the most important information that we'll get is through our direct conversation and discussion with the individual living with pain. Oh, I've got a random arrow there. So in our interactions with people living with sickle cell disease and pain, we'll start to try and build a picture of how persistent pain is impacting on the various aspects of their life and the interactions between those different aspects. And the illustration that I'm going to bring up is really quite oversimplified, and often these interactions are much more complex, and there's a lot of levels, as Jennifer really helpfully described, a lot of levels to the impact that pain might have. But we'll often start to hear people describe things such as, well, persistent pain impacts on my sleep. I struggle now with sleep. My quality of sleep isn't as good. It's not as refreshing as I would hope. That leads to fatigue. And perhaps because of that lethargy, that increased fatigue, university work or my paid employment is becoming more difficult. I might start to see that I'm having days off work or university. There might be other factors that are influencing that as well. So pain might be influencing mobility, and therefore that is contributing to making work or university more difficult to attend. As a consequence of that, someone might start to describe and absolutely understandably experience emotional changes. So stress starts to increase when we're not able to keep up to the extent that we want to and we aim to. There might be an array of different emotions that could come up in this circumstance, but it could be around guilt or it could be about worry or anxiety. We can start to hear and people describe impact on relationships within work or outside of work, potential impacts on finance and earnings, worry, concern about the future. People might have thoughts or describe thoughts such as, I'm not keeping up, I'm no good, starting to affect our impression of ourselves and how we're coping. We might also see one of the patterns that people often describe when persistent pain is around is that much of their energy and their reserves go on the things that really have to happen. People will maintain their most important commitments, their role as a parent or an employee. And often what leaves first, what there's less space for, are the enjoyable and valued activities that really add quality to our lives. So people might start to say, actually, I don't have the capacity to invest in the enjoyable activities, the social activities that I used to enjoy. That might be starting to influence my relationships, communication, my social kind of groups. It might be more difficult to engage in exercise and movement and those activities that are more physical in my leisure time. And we know about the direct correlations between exercise and movement and mood. And sometimes people will start to describe that loss of physical activity feels like it's harder to manage maybe stress or improve mood through movement. So we can start to see quite broad impacts and sometimes knock-on unintended consequences from changes that feel necessary. So someone might describe that now that I'm able to exercise or move less, I'm starting to get more tension and more discomfort in my body. My daily activity is feeling more effortful. And in that circumstance, it would make sense that I might avoid movement and activity a bit more. I might feel less able to do it. And then we can start to see these really tricky cycles developing where activities might become more difficult over time. So, you know, these are examples, and it's really vital, like we've been talking about all afternoon, that the specific impacts, the specific related thoughts or beliefs, feelings, physical impacts and behavioural consequences that are unique to the individual are really drawn out and understood by the team that are trying to work with them. And the pattern and impact of pain will be different for everyone. But what we commonly see are that a lot of effort is being put into trying to manage and adapt to living with pain. But when pain persists over time, often unhelpful cycles can start to develop, and it can get harder and harder to maintain the level of movement, activity, socialising, relationships, function that people would like. So what pain management aims to do is really to try and tap in to various aspects of these changes and support individuals in making small changes that might reverse some of those less helpful cycles and start to help them to work back towards valued activities, for example, to start to have a really helpful understanding of why, of course, mood might be affected in this situation, but what can I do to help to manage my mood the best that I can? How can I maintain relationships and communicate well about what's helpful for me so that I don't feel maybe that I need to miss out on socialising to the same extent? So we're really working in pain management programmes on all of these broad effects and trying to help people to have a range of strategies that they might be able to use to manage these consequences of pain. So why do this work in a group? Why not just do this individually with people? We don't always work with people in a group. There are some people who work best in individual sessions, and individual work is really the ideal for them. But for many people, group pain management programs are useful because it can be really helpful to normalise difficulty. The difficulties that people living with persistent pain describe are really understandable. But often people describe feeling very alone in their experience. And when we can help to normalise difficulty and people can listen to other individuals who share their experience and can relate directly, particularly with the same disease process and experience around all the complexity of sickle cell, often people describe that is a really empowering and helpful experience. We also know that the impact of learning from someone else who shares experience is often more powerful than suggestions made by a professional. So often in a group, people will talk about, oh, that really resonated when that other participant said that they tried that and it was helpful. So I thought I'd give it a try. And so the group effect can be really useful in shared learning and building motivation for change. And also the group effect can have a really useful social kind of element, and many of the groups that we've worked with have stayed in contact beyond the group and provided support for each other beyond the end of the pain management programme. One of our recent participants on our virtual group kind of talked very nicely about the benefits of group work in this statement. She said, as the weeks progressed, I became more and more comfortable and felt safe to share my experiences as everyone opened up about things they've been through. Each week I looked forward to the next session because it felt like a release, and I was learning a lot from others, a sense of validation and motivation, especially since we'd been in lockdown for a year. And at the start of the year, I really did feel alone, but the group has made me feel like I'm part of a family. I never thought I'd end up feeling like this, especially without physically meeting my peers. So that group effect has offered something really, really helpful for this individual. So just to briefly give a little bit of information about our programme at St George's, Breaking the Cycle. Since 2016, we've been running a face-to-face version of our programme. It's an interdisciplinary programme run by myself as the physiotherapist and Dr Jenna Love, clinical psychologist. And our face-to-face format followed that of many pain management programmes, with 8 weekly sessions for 4.5 hours and follow-up at 1, 6 and 12 months. So like most services through 2020, we've been adapting our service to remote delivery. And we have recently completed 1 cycle of the first 10 weeks of a remote version of our pain management programme. So we've adapted the format to make the session shorter because we felt that would be important and more manageable for a remote programme. And we've run a 10-week block rather than an 8-week block, and we'll continue to have follow-up at 1, 6 and 12 months. In changing the length of our programme, that has impacted quite a bit on the amount of time that we have with our group. But the things that we've kept in that are really, really important in terms of delivery of a pain management programme are around the collaborative style of working. So pain management programmes really need to be about shared goals and working towards the individual goals of the members of the group. Really important that we facilitate open discussion to enable that learning from the group and to enable that sharing of experience and knowledge and wisdom that's held within the group. We've tried very hard in remote delivery to maintain the experiential component of the programme, because we know that education alone isn't a very powerful producer of behavioural change. We need to do things differently in order to get behaviour change. So we really want to hold on to that. And we've really worked hard to retain the reflective element of the group. So people describing what they've been doing differently, what they've learned from their experience, how they might do something differently the next time, how they might improve on the changes that they're trying to make. So all of these elements are really important within a pain management programme. And in terms of kind of the themes, the topics, the things that we discuss, I won't go through all of these in turn, but we talk about impact of pain, values and goals, the individual values that we hold as people, and how pain might influence how we demonstrate those values and how we can return to living a life that reflects our personal values. We talk about making sense of pain, specifically in the context of sickle cell disease and understanding the disease process, the experience of acute pain and persistent pain and how they might show up differently, how we might manage them at times differently. We look at activity, movement, exercise, managing mood in relation to pain, communication strategies. We have a friends and family session, which was really well attended in our remote programme, which was a real bonus of that format. And we look at flare-ups, periods of increased pain and maintaining change over time. And between sessions, really importantly, people focus on their own personal goals that they share and discuss with the group, reflect on difficulties that might have come up. And each week we practice mindfulness, brief mindfulness practices, with the aim of increasing awareness of our own thoughts, emotions, physical sensations, and learning a degree of choice in how we respond to those things. We also practice breathing practices, which we know can have quite a soothing effect on the nervous system, and integrate movement and exercise practices each week. So I was thinking a little about who might be attending today and some of the thoughts of how this information about pain management programmes might be useful in other more brief clinical interactions. And I guess some of the things that stood out were that if we listen to the specific impact that persistent pain is having on an individual's life, that can not only be supportive and empowering and demonstrate our interest in the individual and help to foster a good therapeutic relationship, but it can also help the individual in starting to see maybe areas that they could change or would like more support in changing. So that's something that we can do. We can discuss what's important to the individual in terms of the impacts pain is having and try to identify small goals that relate to their personal values. So something small and meaningful that could change. And when we work collaboratively to make those small changes, we can potentially acknowledge that a small change in one area can sometimes have a positive impact in other areas. So if I can start to go out for a walk a little bit more regularly, I might notice, oh, actually, that has a brief impact on my mood. I feel a little bit better for that. And actually, I feel a little bit more alert for a while after that walk. And I bump into someone in the street, and actually, that seems quite good. So I can start to notice that positive change that can occur. And then the other thing that we can do from brief interactions is consider when more intensive work with an interdisciplinary team and referral to a pain management service might be helpful and appropriate. So I think that's all I was going to zoom through today. So thank you for listening, and please do get in touch if you've got any questions or you'd like to consider any more contact with our team.
Thank you very much, Rebecca. I'm sure there'll be a lot of questions and discussion for the panel. So can I suggest that if people have a question, they raise their hand, and I'll try and sort of direct the questions to the panel members.
Mark Lola has a hand up.
Yes.
Can I ask a question? Thanks very much, guys. That was wonderful. I really enjoyed that. A lot of food for thought, and a lot of ideas to take away as well. My question is directed at Jeremy, and I did put it in the chat box. And I think one of the biggest challenge, as you know, that we have, particularly managing patients with sickle cell disease, is not necessarily that staff don't understand what sickle cell disease is or the needs of the patient. I think the biggest challenge we have is to do with attitude. And if your attitude is negative to one particular patient group, evidently your advocacy would be compromised. Your ability to be emotionally supportive would be compromised. And I think the biggest challenge for me, being in this field for so many years, is the inability to teach about attitude rather than about skills.
Yeah.
You can't use your skills if you've got the wrong attitude.
Yeah. Yeah.
So I just wanted you to comment on that.
Yeah, I think people just get a bit burnt out after a while. I mean, working with sickle cell means, as we've said, people come to hospital and they're in pain, and we may be able to patch them up for a little bit, but they're going to come back again. Or maybe we can't. Maybe they come into A&E and you give them some pain relief, but they're still in pain and they have to get admitted. So a lot of what we do doesn't work, and so it's easy for people to feel like, well, there's not really much I can do, right? And I think when people sort of know people are in pain, but there's not much they can do and they're not getting much payoff, it's pretty easy to get burnt out. And so I think the remedy for this is, one thing I often do with people is something called a compassion meditation. You can find it online. And it's something where you basically just practice noticing that, when someone hurts, when I hurt, I feel a certain way. When someone else hurts, they feel the same way. Their hurt is the way I hurt. And in the same way I want myself to feel better, I want them to feel better. And in the same way that, I would want someone close to me to feel better, well, what if I was just acquainted with someone, but they weren't my best friend? I would also want them to feel better. And what if I didn't know that person? Would I not want them to feel better? Yeah, I would. And so, and it goes on and on. And although we call it a compassion meditation, the actual practice among people who do this regularly, they call it loving kindness meditation. And I think love is really the important word there. I don't mean love in a kind of a sexual or inappropriate way. But I mean love more like brotherly love, or you know,
Romantic type of love.
Yeah, or even in a Christian context, you know, agape love is what they call it. So it's it's the desire for, you know, all of humanity to be well. And so, you know, I could suggest that all of you should practice loving kindness meditation, but nobody ever does. So I won't do that. I'll give you a quick little life hack that I saw online, which I think is good. And this might seem weird, but again, this isn't, when we talk about love, it's not like a sexual thing. But there is a little trick that you can do, right? Before you open your mouth and try to talk to someone that you're working with, if just in your mind, not out loud, but just say to yourself, when you're looking at this person, I love you. I really, really love you, right? And just try to feel that, and then interact with the person, right? Okay. It might take some practice, and it seems really flaky, but what you're trying to do is just motivate in yourself just a slightly different sort of perspective where you're looking at the person. Like, I really love you. I want you to be well, right? And I think if you can do that, then even if, you know, you're saying more or less the same things, it's going to land differently. People can actually tell when there's that different feeling. So anyway, that's what I'm suggesting. That's making the rounds on the internet. We'll see if that actually works very well. But give it a try. Give it a try, and let me know how it goes. Yeah, you might see a difference with patients, and you might see a difference with yourself too. Okay, thank you. You're welcome.
Jeremy, I would just add to that we're all working in healthcare.
Yeah.
The emphasis on care is very important. You know, we tend to think of care as being medical management, but actually care has much wider connotations.
Yeah, showing the person that you really care about them, right? If saying I love you seems too weird, just say to yourself, like, I really care about you. I really, really care.
There's a question or comment from Shiana.
Thank you. Thanks for all the lovely presentations. They're all really interesting. Rebecca, my questions were for you. Firstly, I was interested to find out how you select your patients for the pain management programs, and secondly, what sort of feedback have you had from the patients who've been through the sessions?
So selection is, I guess, there's a couple of layers, because compared to some services, we have quite relatively small numbers of people coming through. There's a little bit of selection based on just when the next pain management program is likely to be. You know, we manage to run maybe 2 pain management programs a year. If we had many more people, we would run more programs. But if we know there's a program coming up, we will discuss that with someone. And if we know it's going to be quite a while, we'll discuss whether they'd like to wait. But sometimes people would say, I'd rather do some individual work than wait for a pain management program. So there's some practical selection, I guess, is what I'm saying. The other ways that we select are looking at the impact of pain. If we think pain is having an impact on lots of aspects of this individual's life, and they're describing that they'd like to be able to make changes in a few aspects of their life, and they would benefit from physiotherapy and psychology input and the input of other people with lived experience, then we would talk to them about the programme, and if they were interested and could commit to attending, then we'd consider them for it. So through assessment, through discussion, looking at their outcome measures like I talked about, and seeing, you know, the extent to which different aspects of life are impacted by pain, and yeah, working on an individual basis in that way. Does that answer your question?
Yeah, that does. And has it been well received? And have you seen, for example, that it sort of reduced maybe hospital admissions or?
So the patterns around things like hospital admissions are complex, and we have looked at some individual people's outcomes and seen for some individuals that those admissions have changed. We do see overall, so on our outcome measures overall, we do see increased self-efficacy, we see improvement in mood, we see improvement in function. We're in the process of writing up our data from our patient-reported outcome measures from our face-to-face programmes. So hopefully we'll be able to share that in more detail with you soon. So yes, we do see a positive change in those outcome measures, which is at a relative extent to that you'd expect in a general pain management programme. So that's really encouraging. You know, it's in line with what we might expect to see in a general population. And in our patient feedback, you know, people find it more helpful than others, but our general feedback, yes, people talk to us about the changes that they've made and the improvements that they've seen generally.
Thank you.
Rebecca, can I just add to that a question that I thought Shiana might be about to ask, which was how translatable these approaches are to pediatric practice, and I'm asking that because although arguably chronic pain is probably not as big an issue among children with sickle cell disease, the impact of pain in terms of loss of education and social impact is every bit as significant. And one of the things that I think those of us who are used to looking after adults with sickle cell will appreciate is that sometimes the adaptive strategies that have developed during childhood can be to an extent counterproductive and make it more difficult to manage chronic pain in adults. And I wondered if you had any comments on that.
Yeah, my personal clinical experience is with adults, but we do, I guess, where it's a really interesting thought, because I guess where our focus is moving a little bit more is to transition and doing more transition age workshops, so kind of 16 to 20, and looking more at trying to integrate more self-management strategies earlier at that point. But I think you're absolutely right that that's almost, for some people, almost still a bit too late maybe, and yes, whether pain management approaches even earlier and working systemically with the family and looking at the way that the whole unit kind of manages and understands pain could be very helpful. And there are Great Ormond Street runs some pain management programs for different persistent pain and joint hypermobility, and so there are paediatric pain management programs for other conditions, but I don't know that there are any, certainly in the UK at the moment, for sickle cell. But yeah, it'd be a really interesting area to look at.
Kofi, would you like to add anything to that from a paediatric perspective?
Yeah, I think just from experience, early intervention definitely helps a lot. But as you say, Mark, we don't tend to have a lot of children with chronic pain, although you might see some with, for example, avascular necrosis. And I think it's just about using more or less the same kind of approaches in terms of trying to determine what might be useful. Children, surprisingly, are a bit more resilient, especially at an early age, and they kind of like easily, I'll say, buy into that kind of concept. They obviously, with guidance with parents, they tend to utilize sort of some of the tools like using diaries these days, you have things like apps, and I tend to use a lot of those as well in terms of getting them to self-monitor and trying to work through, you know, that sort of concept a bit more. Yeah. Thanks.
And there's a question from Mercy.
Yeah, thank you to all the speakers. I must say I've learned a lot from everyone that has spoken today, and also from the patient perspective. One of our patients has actually gone through the program at St. George's, and she has found it really beneficial. So she said she was the first to draw my attention to the program. And I'm not sure how it's affected her long term, whether she's still benefiting from it. But immediately after the program, she thought it was very useful. And I'm just wondering that although we don't seem to have so many of our patients with chronic pain, they're a number, but I don't think they're a huge number. But the problem we have is people that come in often for short-term pain crisis, and they're almost in and out of hospital. Would you accept a referral from this type of patients at your end for the program? Is this something we can suggest to some of our patients who seem to come in and out of hospital?
Jeremy might want to answer on this as well in terms of Hammersmith's perspective, but yeah, I think so. The pain management program is one part of our pain management service at St. George's, and yes, if someone was struggling with admissions, very frequent admissions, it might well be that either the pain management program or some individual work looking at self-management approaches around those periods might be beneficial. So I think my gut instinct would be say absolutely get in touch, and we could discuss with them more and start to build a picture of the pattern that was emerging, and see, yes, whether either individual work or a group program might be helpful.
Yeah, I would just add, I mean, in the round of the group that we ran the year before COVID, you know, we actually got some good results on the people who were able to attend, even though those people didn't, those two didn't come to hospital very much. You know, their daily pain ratings improved dramatically. What we actually found was there were some people who came into hospital so often that they couldn't actually attend the program consistently, and so they didn't complete. And so, you know, for the program, we'll be looking for people, you know, what I would call the sort of Goldilocks zone of admissions. They have to come in often enough to derive some benefit, but we wouldn't want them to be, you know, having extended inpatient admissions for so long that they're going to miss every session. So certainly someone who's coming in frequently, but for short duration, they definitely have room to improve. So I think they would be appropriate.
Thank you very much. Thank you.
There's a comment from Verna Davis in Manchester about the positive impact of changes with interventions being introduced during the paediatric period, which is interesting. It sounds as though quality of life measures are going to be very important to evaluate the benefit of pain management programs, and are there existing tools specific to sickle cell disorders that we can adopt for that purpose?
Did you want to take that, Rebecca, or do you want me to jump in?
Well, you can in a minute. The measures that we use at St. George's are largely drawn from general pain management.
There's one that has been developed,
isn't there?
In the States, yeah, but it's
the ask.
I mean, you can use it. I find the sickle specific ones to be quite lengthy, to be quite honest. But yeah. I think combined with some of the standard, what you call generic measures, because they are quite brief, I think that might be a way of looking at it.
I suppose the reason for the question is that if these interventions are going to be rolled out more widely as part of management in sickle cell disease, then we are going to need evidence to support them, and that evidence might not be as simple as, you know, reduction in length of stay or reduction in frequency of hospital admission, but there may be more subtle but from the patient's perspective equally important benefits that need to be quantified in order to justify developing a service of this kind.
Yeah, I suppose there are two aspects of that actually, and Rebecca did show some of the standard, what you call psychological measures, because in one sense you want to be able to compare it with other pain programs generally, for example, but at the same time you want to also, you know, find differences in sickle specific. And I think probably the focus has been in being able to compare it with other more generic services and saying that, you know, you can still find the same different outcomes in terms of improvement, but at the same time, if we can incorporate some of the sickle specific, which have just been developed in recent times, could be useful as well. Thank you.
And something we haven't talked about today is the role of long-term opioid medication in management of pain in sickle cell disease, and clearly there's been something of a sea change really in thinking about the appropriate use of opioids in pain management, and now recent guidance from NICE that they should not be used in chronic persistent pain without an underlying cause. And there are some data which suggest that patients on higher doses of opioids experience more pain. And I just wondered what the panel's views were on that, and how we should be trying to translate that into advice for our patients.
Yeah, I mean, I'm happy to jump in first, but I mean that was really the focus, I think, with my presentation today was, I mean, certainly if we want to make people feel better, at least in the short term, yeah, if we give them an injectable opioid, that will probably help, but we know that it's not going to help them long term. We know it's over the long term, it's probably going to make their pain worse. And so, and with these, you know, there's lots of guidance telling us not to keep doing this, but if we don't have other options, you know, we feel, you know, the clinician feels immense pressure to do something, and if the only tool in your toolkit is injectable opioids, that's what you're going to do. And so I think what we need to really think about is how can we support the patient without opioids and convey that we're doing this because we care about them, because we love them, you know, to allow us to actually prescribe less opioids, and have us do that in a way that isn't perceived to be punitive. We need to actually do it because we care about them, we want them to be better, and we think this will actually help them. Yeah.
That's not always an easy message to get across.
No, not at all. Not at all.
Yeah, I think the key thing is also, you know, the concept of complementary therapy. So, but it's trying to get patients to buy into the idea that apart from, let's say, opioid use, there could be other things that can be done. And I think from Rebecca's presentation, it just shows, you know, in terms of trying to, in a way, break that cycle of people just thinking about opioid medications, but to think about other things that, you know, especially when it comes to that chronic pain or you know, frequent pain, that, you know, we need to be able to incorporate, you know, some of the different things. I mean, I don't know about you, Rebecca, but I tend to use things like, you know, offer things like TENS machines, or, you know, in the good old days, actually GPs could help patients for other complementary therapies, like, you know, whether it was aromatherapy or things like that, and even incorporating some of the principles of physio in terms of hydrotherapy or whatever. You see what I mean? Just to offer patients some other options, which may not necessarily take away the use of opioids completely, but at least it starts to break that cycle, so to speak.
There's a question from Mamta.
No, I was just going to say that sometimes that's easier said than done.
I know.
Is all I wanted to say. But we used to have, years ago, I remember as a registrar, we used to have someone who used to do massages for patients. And I think, that actually really helped, but that's not available anymore. But yeah, it's a small minority, but there's who don't want to engage, and I personally find that very, very difficult. I'm sure everybody does.
Yeah.
I guess the key point or take-home message there is being in a position to provide patients with alternatives, which until recently has been very difficult.
Can I just ask? Sorry, I have my hand up.
Yeah, Mercy. Yeah.
Yes. What is the role of neuropathic agents in these patients? We tend to put in neuropathic agents rather than opioids on the long term, and we're getting a lot of benefit from this. Like I've always said in several meetings, upon almost over 400 adult patients that we have, we probably have 5 of them or thereabout on small doses of opioids in the community. But we have a lot more of the patients on neuropathic agents like pregabalin, gabapentin, and to good effect. But it doesn't seem to be a prominent part of pain management in other trusts. I just wonder whether there's any literature, any experience with this.
Yeah, I would agree that where it feels appropriate, that we're lucky to work just one session a month with a pain consultant with a special interest in sickle cell disease. And often when he runs his clinic, he will absolutely look for those options as well. Is there more of a persistent pain picture that might respond well to more neuropathic agents? And yeah, try to move in that direction. And for some people, it does seem like that can be a very helpful option. Yeah.
I'm not sure whether that has been tried or whether there's any use of that at Imperial.
Yes, we don't have a dedicated pain consultant within our multidisciplinary team, but we have access to specialist chronic pain management and neuropathic agents, particularly pregabalin and duloxetine, are quite frequently used and helpful in some patients.
Thank you.
So I think if there are no more questions or comments, just remains for me to thank all of the speakers for what's been a really fantastic session this afternoon, and I think points us towards some grounds for optimism in managing pain in our patients with improved outcomes. And I'd like to thank Jennifer particularly for giving that very personal and insightful view, which I'm sure all of us benefited from. So thank you again.
Thank you.
So I think that that brings us to the close of today's session.